We'll talk about this morass down here in just a moment. So again, at the level of the hip, here's the iliacus in this region. Here's the psoas descending, and then they'll converge down here to form the iliac psoas. You can see this pectineus, which we talked about earlier, is primarily a rotator of the hip. By the way, the lateral rotation just means that the front of the foot is moving to the side, so as opposed to medial or interior rotation.
Is that a lateral rotation?
That's what yeah, this would be a lateral rotator. Most of these, well, yeah, most of those little small muscles in that region are. But one could argue they also contribute to flexion too, so that's why they're usually included in these illustrations. Now down here we have what's called the patellar retinacula, sort of implying a plural. I think we have a better illustration of this later. There's the ligament of the rectus femoris, and then it continues. We normally say that this ligament continues over and across the patella as the patellar ligament. So this is considered one structure for the most part. And then you can see you have a whole network of ligamentous structures that sort of bind together around the knee. But collectively, they're referred to as the patellar retinaculum. Now, when we use the word retinaculum for other joints, it'll have a slightly different meaning. But what it always implies, or what the term retinaculum applies at a joint, is it's binding around the joint, rather like a sock or a ace bandage, sort of binding the tendons and connective tissues together. As I've indicated, there's a little reference here to the fact that some muscles act on one joint, some muscles act on two joints. I have a much better table for that, so let's not worry too much about this. All right, moving to the medial, these are the adductors. The medial thigh muscles are the adductors, adductor longus, brevis, and magnus. You can see the magnus over here, the adductor longus, and then that's the pectineus, which is really more of a rotator, to some extent a flexor, but it's also included within the adductor group as well. And as you can see, even the gracilis, which is here it is. The gracilis would be a very medial muscle over here, and sometimes included with the adductor, but it's very weak and contributes only in a very small way. The obturator we will look at later when we talk about the pelvic diaphragm. It's really more of a supportive muscle in that connection than as a articulator of the femur. And then our final group are the posterior thigh muscles. These are the hamstrings, and we'll find that they have some interesting anatomical attachments. But what I would have you pay attention to in these figures is the relationship of the tendinosus and the membranosus to the biceps femoris. So make sure you note that the tendinosus and the membranosus descend medially. So they're going to descend over here. And the biceps femoris is going to descend on the opposite side. And then together, then, they're going to sort of frame what we're going to call later the popliteal fossa, that little hollow in the back of your knee there. Now, with respect to the tendinosus and the membranosus, we said that generally the membranosus runs deep proximally and medial distally. So in reality, it's a thicker, broader muscle that runs on either side of the tendinosus. We've looked at this before, just make sure you understand the trajectory, the pathway of the sciatic nerve. And of course, they're pointing out some of these other muscles as well. You can see the adductor magnus there. You can see the semitendinosus tendon quite prominently here, tendon of the biceps femoris, which sort of runs along that fibular nerve we'll look at in just a moment. Now, you may find this slide useful. This is something I think you learned in grade school as a Venn diagram. If you find it useful, great. If you don't, just chuck it. But here's my intention. Here's what I was trying to convey by this Venn diagram. We have the three groups of thigh muscles here, anterior, medial, and posterior. And associated with each of those is the predominant nerve innervated innervating each of those compartments. So the anterior compartment is innervated primarily by the femoral nerve, posterior primarily by the sciatic, more specifically the tibial branch of the sciatic, and then the medial primarily by the obturator nerve. So you should know that. And you have that information in an earlier slide as well. But at where these circles intersect, what have I included? I've included three muscles, the pectineus, the biceps femoris, and the adductor magnus. They're a little unusual in that in most individuals, not all, but in most individuals, these muscles, the pectineus, biceps femoris, and the adductor magnus, have dual innervation. And so by that we mean that we normally include, let's say, the biceps femoris as part of the posterior group, but it actually received innervation from the femoral nerve and the tibial nerve. All right, so that's all that means. So the pectineus would receive dual innervation. Pectineus would receive dual innervation from the femoral nerve and the obturator, even though we normally classify it, I'm not really too concerned about this, we would classify it as part of the anterior group. So again, if you find that confusing, just disregard everything I said. But it makes it helpful. Now this is a table I would encourage you to just go ahead and memorize, because what this table summarizes is the fact that some of these muscles act on only one joint, and it's specified where it's indicated there. Other muscles act on two joints. Now you'll find that these fall into rather helpful categories. For example, the adductors. All of the adductors that we talked about act exclusively on the hip, just one joint. What do the vastus family have in common? Which compartment are they in? Anterior. So the vastus act exclusively on the knee, and that's virtually the entire anterior compartment, with the exception of the rectus femoris. And the rectus femoris is unusual in that it extends over both the hip and the knee. But for the most part, the vastus are all just acting on the knee. And then over here, you have a couple of powerful muscles and a few not so powerful muscles, but notice the three down here at the bottom. Which are they? Yeah, those are the hamstrings or posterior compartments. So they extend across both the hip and the knee, so they act on two joints. And then you have, again, these two rather small muscles, the sartorius and gracilis, that also extend across the hip and the knee. And then I just threw these terms in because students have asked about them so often over the years. You should be familiar, I think, with the correct definition of hip pointer and Charlie horse. The hip pointer, probably can add a little bit to this, generally involves bruising around the iliac crest and sometimes the upper trochanter too. That's often considered part of a hip pointer. Charlie horse, on the other hand, is just bruising, a massive bruising, usually of the anterior muscles, anterior compartment muscles. The gluteal arteries, you can see them illustrated here. These are important, and again, flexion and extension of the hip. We're looking here at the superior gluteal, the red is the superior gluteal, sort of descending there. That's the inferior gluteal. We've already talked extensively about the femoral artery. Just want to remind you of its general transit, emerging as it does from the femoral triangle, entering the adductor canal and emerging posteriorly at the adductor hiatus, which we see there. And we're going to find that it extends through the popliteal fossa to branch into two smaller vessels. Recall in our previous discussion of the femoral artery, we found that at about the level of the inguinal ligament, the femoral artery gives rise, it branches into the profundus artery, the deep femoral artery, and that's the deep femoral artery there. And then that deep femoral artery will extend branches and anastomosing branches to the posterior compartment of the thumb. And those arteries, those branches, are sometimes called perforating arteries, as we discussed previously. You should know that the obturator artery, by the way, the most difficult, I've always found the most difficult aspect of the discussion of the limbs is differentiating the terms we use to describe the nerves from the terms we use to describe the arteries. So here we're talking about the obturator artery, and all you need to know there is this is a medial artery that supplies the, for the most part, the adductor group, the medial group. The femoral vein more or less corresponds in its anatomy to the femoral artery, keeping in mind that this is a deep vein which carries a broader or a larger amount of blood returning to the heart than do the superficial veins of the lower limb. And because it is a venous comitatus, you should not always assume that, as the illustration shows here, it has a discrete unitary appearance. These large veins can have a variety of shapes and configurations. Again, by way of review, here's our femoral nerve up here, and that femoral nerve is going to branch into a variety of largely cutaneous branches. These are the cutaneous branches you see, but that long one, of course, is the saphenous nerve that we saw, at least initially runs through the adductor canal, and then you can see it sort of branches off medially. And that will extend all the way down into the foot. Now we followed the sciatic, and actually we had several illustrations. We followed the sciatic down to the knee. It sort of joins up with the structures in the adductor hiatus, so that all three, you can see that here's the sciatic coming down. It's then going to branch into the tibial and the common fibular, but running with the femoral artery and nerve, they're going to change names at this point. They're going to be called the popliteal artery and vein, is the tibial nerve. So all three of these are going to be running through what we're going to call the little hollow in the back of the knee there, the popliteal fossa. Now, here's a good summary. I would probably encourage you to highlight this or make a note of this, because we won't have a lot of time later to talk about the complex innervation in the foot. But notice the tibial nerve more or less innervates the muscles in the posterior compartment of the leg. The leg here has a specific term, a specific meaning, referring to that portion of the lower limb distal to the knee. The tibial nerve then innervates the muscles in the posterior compartment of the leg. Most of the intrinsic muscles in the plantar foot. Remember, the plantar foot is the underside of the foot. And what do we mean by intrinsic muscles? We really haven't used intrinsic and extrinsic with respect to the hand and the foot. What do we mean by intrinsic? For example, when you move your big toe up and down, where is the muscle that does that? Right? Somebody in your ear? Where is it? Okay, good. Well, depending upon whether we're talking about the flexor or the extensor, but you're exactly right. My point is it's in the leg. On the other hand, when you spread your toes and bring them together, where are those muscles located? In the foot. So I want you to understand that intrinsic muscles of the foot are housed or reside exclusively in the foot. But as with the flexors of your hand, your wrist, and your fingers, those muscles are back here, extensors back here, same thing with your foot. However, the muscles that enable you to do this with your toe, I can't do that with my toe. That's a very complex motion, but that ability resides entirely within the foot, or in this case, the hand. We'll talk about that later, the lumbricals. And then your ability to do that with your toes also is achieved by intrinsic muscles. And what we're saying is that it's branches of the tibial nerve that supply most of those intrinsic muscles in the sole of the foot. And then the tibial nerve also provides cutaneous or sensory function to the skin of the posterolateral leg and the medial ankle. I have to be careful here. We're going to have an anatomical issue that I'm going to defer until a little later. One of the reasons I'm a little hesitant to be too specific about the innervation down here in this region is because some things are highly variable from person to person in this region, and sometimes the generalizations that you read in the textbooks can be a little misleading. All right, so that's the tibial nerve, and this is the tibial nerve here, and then there's going to be the common fibula. It too is going to branch But the common fibula is going to innervate the muscles of the anterior and lateral compartments of the leg. Remember, we don't have a medial compartment of the leg, it's a lateral compartment. And then the extensor digitorum brevis, that's going to be an intrinsic muscle of the foot. And then also cutaneous sensation in the lateral leg, the ankle, and then the upper part of the foot as well. So what's the
tibial nerve, does it innervate the medial?
Here's one, I said we have to be careful here, because the problem we're going to have, and I don't want you to worry too much about this right now, is that there is a nerve, in fact, I don't know if you can see it, I don't think they show us the nerve here, but there is a nerve that branches from both of these. Some folks have it, some folks don't. If you look at your essential anatomy, for example, that nerve is missing, well, it's there, but it comes directly off the tibial. So, it's some of the generalizations are just inappropriate, so we'll talk about that when we get to so we've talked about the adductor hiatus. The only point that I want to be sure you understand is these were originally, for example, the femoral artery that you see coming from the anterior compartment of the thigh, now is going to move to the posterior compartment. We don't see the vein in there, but it's in there too. And so the first thing to keep in mind is that femoral artery changes name. It's now called the popliteal artery and popliteal vein. And it's no longer coupled with the femoral nerve that it was up there at the inguinal region. Now, all these structures join up behind the knee here in this popliteal region with the tibial nerve. This is going to be the tibial nerve here. So that's our introduction to the knee. So let's turn our attention to the knee. Move inside. We normally say the knee, remember the femur actually enlarges distally. It's the largest of the synovial joints, even larger than the hip joint. It's primarily a hinge joint, even under the best of circumstances. It doesn't afford a great deal of motion. And as we look at the bony components here, which you can see the number of features we've already talked about, you can see the condyles. The condyles are the articulatory surfaces. We can see the epicondyles, that would be the margins over here. And as I mentioned before, as I just sort of make a few points that are very critical, if you imagine a line sort of extends orthogonally from the femur down to the tibia, that wasn't such a great line, was it? You know my problems drawing lines. The point I'm trying to make here is if you imagine a line, you can do a lot better job than I can. The larger bulge, the greater bulge is the medial. All right. Remember, I want you to be able to look at the knee, size it up, just from an image like this, and tell me which side is medial and which side is lateral. If you happen to see the fibula, then you've got a big clue. You know the fibula is on the lateral side, but you may not necessarily see that. You have some other clues as well. But that's one very important clue to keep in mind. Not always true, because you're going to be dealing with knees that are massively altered through chondromalacia, arthritis, and deformation, and that's not always true. But in general, the greater bulging is to the medial side. Indeed, as you as a PA, as you're dealing with orthopedic knee issues, it's important to keep in mind that most of the weight is on the medial side, so that you would anticipate under normal circumstances, barring an athletic injury, barring a trauma to the knee, greater deterioration, greater attrition, greater abrasion on the medial side. Now, in these introductory images, again, you can see the condyles, you can see the epicondyles, you can see the tibia and the femur there. You can also see the collateral ligaments. These are the collateral ligaments that extend from the superior bone to the inferior bone. And then the image on the right, we see the cruciate ligaments. You can see the anterior, you can probably guess why it's called that, and the posterior cruciate ligament back there. And of course, we're looking at the patella here. We saw the patella sort of suspended in that web of connective tissue previously. really like this illustration, but what it's attempting to show, what we're looking at the condylar surface, and here's the patellar surface down here. All of that pink that you're looking there, that's the synovium of the knee. As I said, I don't think I want to spend too much time with this illustration, but you can see the external capsule here, and then the interior synovial capsule. We'll have a better picture of that condylar surface also. I've made several references to the synovium. Now the synovium, as you can see in the illustration here, is sort of a fluid sac. If any of you have front wheel drive cars and you have little transaxles going to both of your front wheels, you'll have a little rubber boot, and that rubber boot protects the transaxle and all the innards in there, and it's usually filled with grease to facilitate the rotation and movement. In fact, sometimes you have to replace the boot and the grease. Well, this is kind of what the synovium is doing here. It's sort of a boot surrounding critical portions of the hinge joint, filled with lubricant that afford and allow a greater, a freer movement than would otherwise be possible. So this illustration, I think, is a little more instructive than the one we were looking at before. Here we can see the femoral, we can see the superior and inferior mating surfaces of the knee joint. We can see the condylar surfaces on both the lateral and the medial side here. And then you can see what are down here. These are termed menisci or meniscuses, both terms are used. So this would be the meniscus and the meniscus here. So that's the lateral meniscus, that's the medial meniscus. Now, in looking at this image, what do you notice? Do you notice any difference in the attachment of the medial and the lateral meniscus? Again, this is the meniscus here, and this is the meniscus. Do you notice any difference in the way that they're attached? Yeah, notice that the medial ligament is attached to the collateral ligament. I'm sorry, the medial meniscus is attached to the collateral ligament. But that's not true over here. This one's free. It can read, it can move around. So these meniscal surfaces that you see here, again, these are articulatory surfaces. They should be fairly smooth. They should be protective. They should act as cushions. They should act as intermediaries between the two bones, to prevent the two bones from abrading. You can see that they have this sort of lunate appearance. We talked about that term as we talked about the hip joint previously. And the other thing I think is quite evident in this illustration, as you look at the overall organization, you can clearly see the external capsule. Remember, the external capsule of a synovial joint consists almost always of ligaments, sometimes tendons, but ligaments for the most part. So that gray tissue that you see out there at the perimeter, that's usually some type of ligamentous or aponeurotic tissue. And then the pink or purple, whatever color that is, that's the interior capsule, the synovial capsule. But again, both terms are used, synovial or interior. And so what do you notice about, these are the cruciate ligaments here. Are the cruciate ligaments within the internal capsule? No. All right, so you can see there are a lot of structures that are not part of the internal synovial capsule. For example, all this fat that sort of wraps around the condylar spaces and the infrapatellar region. All of that is outside the synovial capsule, but is contained within the external ligamentous capsule. You'll also notice several of the bursa we looked at in respect to the hip joint. There are also bursa at the knee. Some of these are in association with the synovium, and some are not. For example, this thing up here, this very large patellar bursa, suprapatellar bursa, is in certain area is continuous with the synovium, in other region, in other areas it's not. But it's a very large protective bursa. All right, so here, this is the point I was trying to make earlier. Just wanted to make sure you saw that medial meniscus is attached to the medial collateral ligament. The lateral meniscus is not. And as a consequence, you will often read, I'm not sure I buy this, but you'll often read that the medial meniscus is more prone to damage, more prone to injury for that reason. The logic being that the medial meniscus is unable to move around, unable to shift to accommodate the changes in load by comparison with the lateral meniscus. I think more likely the reason this medial meniscus tends to deteriorate more rapidly is there's more weight, there's more load, there's more trauma on that meniscus. But in any case, that would certainly be true. We talked about the position and location of the patella. We can see the articulatory surface of the patella there. It has the inferior border of hyaline cartilage, articulates with the surface of the femur. It is sort of suspended out there in the anterior knee by ligamentous tissue. It's sort of the usual explanation. You can see the patellar bursa there. Here's the patella, and then you have the ligaments that extend to it from above and below, sort of placing it under a high degree of mechanical stress, depending upon the activity of the knee and so on. But it tends, the usual explanation is that it enhances or increases the mechanical purchase of the attached muscles. In other words, if you imagine it way out here, those muscles would have even more mechanical advantage, and they have more mechanical advantage attached to the patella than if they attached interior to it. It's also protective. I had a nursing student last semester that could take the patella and push it to one side of the knee or the other. I think she said because it had been injured so many times. And then sometimes the patella will actually not be fused. Sometimes individuals have the multipartite patella. So be sure, I think we've talked about the difference between the cruciate and the collateral ligaments. In general, when we talk about a collateral ligament, we're talking about a ligament that directly attaches to adjacent bones. All ligaments don't do that. Sometimes ligaments attach obliquely. Sometimes they attach transversely. We're going to find one in the elbow, for example, that actually is a sort of a radiate ligament. But a collateral ligament always is more or less direct attachment between adjacent bones. This illustration is pointing out that you have both structural and soft tissue components of your knee that tend to allow it to lock in the vertical position or the erect position. And then, in fact, a special muscle is required, or at least a special muscle facilitates the unlocking or the detachment. Now, you've probably been told, what have you been told about locking your knees? Did your parents talk to you about locking your knees? Probably not. What? Okay, so you popped right to it. All right. And Professor Sparker is going to talk to you at length about that. Evan said passing out. Anybody familiar with that? You've probably seen videos, YouTube videos of somebody at a wedding or marching band individuals standing there and they just fall down. Type of syncope. I give you the knee. You tell me, is there anything about standing? Is there anything about the knee, locking the knees and standing, that would cause you to pass out, go into syncope? Anybody have any thoughts?
Do you lose preload because you're blocking some vein that returns blood to the lower leg?
Well,
And is it significant enough to cause syncope?
So you can see, I think so the implication of your question is what? I guess I would repeat the question. Do you think that are you aware of any structure in the knee that would be responsible for that response? No. Yeah. So I just want you to understand that when we talk about the knees locking, and I'm sure you've been taught about I can't lock the knees anymore. In fact, I barely walk anymore. But you shouldn't expect, oh my goodness, I locked my knee, I'm going to pass out in 15 seconds. There's nothing structural that could cause that. And there are other reasons for it. We get to the cardiovascular, we can talk about that if you want. I just, but there are other reasons why it may not be a good idea, especially as you age, to get in the habit of locking your knees. Nevertheless, nature has afforded us a couple of mechanisms. The femoral condyles, as you can see, become flatter and broader as the joint becomes more vertical and less perpendicular, and that tends to afford greater stability as well. There's a whole range of things. The ligaments change conformation, a whole range of things that happens. And there's that popliteus muscle that helps to, when it contracts, to unlock the knees from their vertical position. Boy, this is a grim one. So this refers to some of the injuries that can occur to the cruciate ligaments. Of course, you'll be dealing with a lot of these. In general, the anterior cruciate, the one in the front, prevents the tibia from moving too far forward. The posterior prevents the tibia from moving too far backward, too far in the opposite direction. ACL injuries tend to be more common, especially with athletic trauma. There is something called the unhappy triad syndrome, which involves the collateral ligament, the ACL, and damage to the meniscus. And then there's debate about which meniscus it is. The general rule is that in an aging or chondromalacious patient with degenerating knees for reasons of age or osteoporosis, whatever, arthritis, the medial meniscus is more likely to be damaged. If it's athletic, it could go either way. It just depends on the nature of the injury. All right. You thought that that hip replacement was tough. You may not want to look at this. I've got a little video here of a Bulgarian sprinter. You've seen this one? All right. All right. You're going to have to compare, because this can get wrong.
Oh.
Let me slow it down for us.
Oh, he's
As
done.
many times as I've seen that, I still sick. But he's good to go. Just put a nice bag on.
Yeah, sure.
There was a Miami running back. And by the way, you might ask yourself, why would that happen? What is unusual about this person's physiology that would be more likely to happen on him than us? Exactly right. He has such powerful quadriceps, upper compartment muscles, with respect to that joint. They're probably unbalanced for running. Probably when he relaxed, those muscles were not, he was proceeding at an angle for sprinting, but the joint wasn't able to handle it when you relaxed the muscle because of the power. Yeah, so pleasant dreams tonight. And of course, if there is ligament, who's the Miami running back, University of Miami running back that had a similar injury, the Gahiers hip. If you ever look at the videos of that, he went backwards too. He went on to be very productive. I don't know if he's doing so well these days. He may still be playing. But of course, when we talk about damage to these ligaments and the tendons, ligaments more so than tendons, it's important to keep in mind that they're not extensively vascularized. If this connective tissue, those capsules that we've been talking about, have been damaged in some way, the collateral ligaments or the anterior cruciate ligaments, these structures do not heal readily. Generally, the only healing that occurs is with scar tissue, which is not very helpful. So as you look at what's going on in this illustration, you can see they have some type of ACL injury. The ACL is torn, and here they're just going to remove what's left of it, and then this is the repair. So why would this type of repair be appropriate? Why can't you just go in there and sew it together? because it's not gonna hold. And you can see the great extraordinary, in fact, I was for your second anatomy assignment, I was going to give you a tutorial on Tommy John surgery, what has to be gone through, the steps that have to be taken there to address the damage to that connective tissue. Sometimes the ligament can be harvested from the patient. That would be an autograft. Sometimes they'll use the semitendinosus or the gracilis tendons. Sometimes it comes from a cadaver, or it can be transplanted, and that would be an allograft. We saw in the previous illustration potential damage to the joint following chondromalacia, progressive deterioration with arthritis. What you usually get is something like this, with the articular cartilage progressively eroding away, and as that articular cartilage erodes away, there's going to be abrasion of the bone on the bone. The menisci are compromised, if not fragmented. You get little chips and fragments in there that can bind and further aggravate the injury. And while all that is going on, in most types of arthritic degeneration, especially osteoarthritis, you get the formation of the bone spurs, the osteophytes.
Now that you have seen how a normal knee functions, let's look at some problems your doctor may find during knee arthroscopy. Diseases such as rheumatoid arthritis, degenerative arthritis, and hemophilia can cause inflammation of the synovium, which is the special tissue that surrounds the inside of the knee joint. Synovium inflammation causes swelling. Because the knee is enclosed, this swelling puts pressure on other structures within the knee, causing knee pain, especially when the knee is bent. Loose bodies inside the knee are often fragments of bone and cartilage that have broken off during an injury or have formed because of long-standing arthritis. These loose bodies can float freely between the thigh bone and shin bone and may sometimes wedge into the joint. When this happens, the knee may lock, causing pain or the feeling that it is going to give out. A tear in the meniscus cartilage may result from twisting injuries or increasing age. Most meniscal tears occur in the back portion of the meniscus. When the knee bends, like when you are squatting, the thigh bone pushes against this torn area, causing pain. Furthermore, a meniscal tear can cause symptoms of your knee giving out, clicking, or catching, and sometimes locking. This occurs because the torn piece of the meniscus can actually move around inside the joint. Because the space in the joint is very small, when the torn piece of the meniscus moves, it often becomes caught between the bones of the joint, the thigh bone, and shin bone. These examples represent some of the more common problems that can occur within the knee joint. Your own knee may not fit nicely into one of these categories, or you may have a combination of problems. For example, your doctor may know from x-rays that loose bodies are present in your knee, but during the arthroscopy, it may be discovered that you also have a torn meniscus that can be treated at the same time.
So in arthroscopy, generally what they'll do is take a little scope in there and they'll have a little drill or a braiding device. And sometimes those fragments that you talk about can be removed. But if anybody looked at the epidemiological literature on arthroscopy of the knee, what would you expect? Would you expect it to be uniformly beneficial? It's not. It's about 50%. In other words, by that I mean patients report 50 on average, half of them report an improvement afterward, long-term improvement. So probably what that suggests is that those deteriorative changes are more complex than was simply described here. So we talked about the popliteal fossa. Just be familiar with that term. Here's our sciatic nerve coming down. Here's the changes to the tibial nerve at this point, and then here the femoral nerve is now called the femoral artery is now called the popliteal artery, and they're going to be all ensconced back there together with the popliteal vein. So all of these structures are going to be contained within that small little opening that you see there between the biceps femoris and the semitendinosus and semimembranosus tendons. In addition, as the popliteal artery approaches the popliteal fossa back here, both the femoral and the popliteal give rise to branches, and you can see the extensive sort of cloverleaf, interstate highway cloverleaf arrangement of vessels extending around the circumference of the knee. We're going to call all of these genicular. So the genicular arteries are these anastomosing dedicated arteries designed to perfuse the knee. There is one that's usually a little larger and more medial of all of these, and just to confuse us, that's the saphenous artery. So we talked about a saphenous nerve, a saphenous vein, and this is the saphenous artery. And it too is, as you can see, is relatively medial in its anatomical placement. And you can see some of the geniculars here. I'm not going to ask you to learn the names, but as always, what I will ask you to do is be able to infer the location from the name. So obviously you should know what superior lateral means and inferior medial. So again, we can see the sciatic nerve coming down, gives rise to the tibial and the common fibular there at the knee. Now remember, I said that when we attempt to allocate function, especially with respect to sensory function, and well, it's almost, the problem is almost entirely with respect to the sensory function. Our task is complicated by the fact that, again, here's our tibial, here's our fibular. But if you'll notice in this particular illustration, there is a very important nerve that, shown here, branches from both. That's called the sural, S-U-R-A-L, sural nerve. Now, in reality, this sural nerve may branch from both, as you see here. It may branch way down here, or it may branch from only one or the other. And that sometimes complicates our ability to specify at least cutaneous function or sensory function. But in any case, we're going, just for the purpose of simplification, we're going to say that the sural nerve branches from both the fibular and the tibial. And then notice, again, the relative relationship of those important structures in the popliteal fossa. You can see the popliteal artery most deep, popliteal vein superficial to that, and then usually you have the neural structures that are most superficial.
In the last section, we saw the principal deep vein of the leg, the popliteal vein. Here it is again, with the tibial nerve behind it and the popliteal artery in front of it. It disappears between the two heads of gastrocnemius.
We're looking from the back. Oh, that's great. So notice in the transection here, we're about at the level of the knee here. All right, so here we go. So here's the tibial nerve here. You can see the popliteal structures there. But notice the position, this very exposed position of the common fibular nerve lateral. I think I saw in one of those war movies, those Middle Eastern war movies that addressed torture. I think I recall learning that this is a common site of torture. This was a common method because they would just keep pounding very lightly on that common fibula, and apparently it can be intensely painful every time. Or keep pounding anywhere to do that, but the exposure of that nerve in particular made it vulnerable. Now, we have just a few minutes here, but I just want to again show you the importance of this anatomy. This is something called a popliteal block, and this is a mechanism by which an anesthetic can be introduced. And once again, depending very much on your knowledge of the relevant anatomy. So he's talking about getting your kit together. All right, so let's pick up about right here.
Superior to the contralateral leg. The lower leg and foot need to be easily visualized to appreciate the muscle twitches generated stimulated by the nerve stimulator. The electrode should be placed on the patient's leg to complete the electrical circuit. Ensure that the posterior surface of the patient's leg is well exposed. Both
On second thought, I think because you need to get your picture, I want to come back to this later. You need to get your picture taken, and does anybody want to look at the anatomy test? I was gonna say, if we can take a few minutes to do that now, and then you can go get your picture taken, that's up to you, if not, you can just go get your picture taken. Anybody want to look at their anatomy? All right, so give me just a second, and then, we can.
I watch it happening, but I don't like to see that happening. I've seen too much, man. It's like, I don't want to see it. Especially basketball. Worst one though is I feel so bad for him too, man. He just came back from another ACL injury. Like that was. Literally, like, for a layup, like, he landed, literally his knee, like, through his like, I mean, like, oh my God. That was bad. I can't watch this guy. I just got my heart like beating, man. I didn't even see that dude. There was, were there, is there one particular question that
So where did I see it? Oh,
Everybody should receive the same.
I just both mine say the same number. I'll come tonight.
Are you the only one? Let me know.
I'll come see you.
Everybody's got a couple.
Save for rainy day, that's right.
Cervical exception. I don't recall the wording of the question.
The diagram? You know the one you said was like down here. The cervical plexus was down here.
Still thinking about it. Just thinking about it. I heard about that one. Oh my God. Especially when I was there. Oh, you got two legs like snacks.
sometime later today, so at least I can find your.
Yeah, that's fine. I'm gonna stay and study tonight.
Okay, I'll just come back up there after.
That's fine. And
Gotta make sure you don't like that
Extra time.
That's right. Or it can happen like this, or it can happen down here. Okay. It can actually below the organs. That's what it says. Usually the organs, not always. And don't forget, you have to pick the best answer, and none of the others are going to make sense.
Or the one was like happens on one side, happens together, and I was thinking the animation with the maxilla.
Is that what you picked the contour two? Would be one side and then do the other?
Well, the way it was worded, I thought maybe could include like a maxillary, and what happens on one side is happening on the other. So,
But there was nothing that specifically said that. There's nothing that restricted the answer to just that maxillary fracture.
okay.
Normally the report, the reason we talked about it in the context of the organ, that's where it's going to come up in clinical practice.
Okay.
You can blow out injury to the eye. In fact, one of the nursing students had a car accident the last week and was walking around with a black eye in the report.
From a report. That's interesting. Okay.
So let me.
yeah, I know we have an illustration of it and I can't find the picture of it, but even this slide right here says structures passing through the parotid gland, and this is external parotid artery. And then we have a picture that shows the three. It's like the
So
narrow parotid.
That's something I didn't see. So that's not quite correct, but that's fine. So what I'll do is. But I'll quit.
Okay, because, yeah, I wasn't sure about it when I looked at the test. Still.
I think I believe you. So yeah, just
Yeah.
so give me some time. I'll try to get you something. See if it's reflected in the rating.
Okay, thank you.
It's actually deep. Yeah, good. Thanks for bringing that.
Yeah, I picked the lies deep to the master because I knew it wasn't the smallest, and I knew it wasn't innervated by the vestibular conda. So it was between the overlies portion and lies deep. And I was like, I know that the external goes through it because that's what this lies.
Yeah, if it hadn't said that, I would still quibble with you about it, because remember your job is always to pick the best answer.
Right.
That's fine. So.
Yeah, and there's a picture of it too. I'll try to find a picture for you as well. Thank you. down there with me.
Yeah. And then by now I should have that photo on Facebook. Like,
What?
that photo.
Oh, yeah.
Doesn't take too long for that to happen.
Everyone got tagged and.
Yeah.
I have to run home because I forgot my iPad this morning. I'm like taking notes on paper. And I gotta go to Target real quick. Peanut chewed through my cord this morning. Oh boy. Your phone charger? Yeah. I was pissed. She hasn't chewed anything in so long. Oh my goodness. You wanna go to Target with me? Kelsey, where are your keys, girlfriend? Yeah, I might join you. Normally I like sit here and study, but I really don't want to. No. Oh wait, well. We can hang out. Okay. Oh yeah. I just have to run into one right now. Oh, let me grab my wallet.
So I'm just a dumb kid now.
Otherwise, I'd get to Target. I'm losing my marbles.
Where'd you get your haircut from? You're not help. I know, man. My barber's in Naples and he's off until Monday, so I'm like.
I just went to the freaking drugstore and spent $95 on hair care stuff because my hair was so tragic before I got it cut that I was like, never again. Put your bag away. I trip over it all the time.
Yeah, Twin. I used to go to Twin back in the day before Twin was Twin. He worked at Latin Creations on Colonial. Yeah. And that was like, they got shut down for some trucks out of there. No, not Twin. Before Twin bought his own like place, he worked for a company called Latin Creations. It was on Colonial 41, right by that bridge in that little plaza. And they got shut down because of multiple things. They were person.
Chill.
My clothes.
Hey, so we have cultural diversity class today, right?
Yeah. They used to sell clothes.
Yeah.
I bought my clothes there.
Yeah. To get you all happy.
So we have class today. That's what everyone's saying. Yeah. All right.
Someone said we didn't have cultural diversity.
Yeah, I know. I don't know.
And I was so freaking excited. I was like, yes. We're out at 12. No, my dreams are
No. The Jamaican place past
Oh, the one that Danica was talking about down by Publix?
yeah, past that one.
No, yeah.
What do you say?
What? I like fucking Squidward.
You were the head of the game. What are you talking about?
I do nothing.
You'll rush you. Whatever. Talk to the hand. No, it's not gonna be good. You're gonna be crabby.
I have almonds too. I do get crabby when I'm hungry. They didn't know that. That's why you like.
What's the part? Like a regular or?
Vidal. Last name is Vidal. Vidal.
Right, yes,
I have no idea what it is.
Ecto.
Ekta? Well, Ekta's Patel.
Oh, no.
What question did you say he was gonna look at?
Yeah.
Oh, it's Ellie. It's right here.
With the cover thing?
Yeah.
Okay. He said he's gonna relook at that one?
Yeah, I guess so.
He ended up giving me half of like three. If you wanna know what you missed, yeah, if you wanna know what you missed. How long ago?
You missed them?
Yeah, cause I think that one wasn't out of his menu, that's why.
Right before we left it.
Yeah, cause it's out of the amount of points that. This one, ninety four would be.
So that who serves that kind of modified his job, he's kept raising my service.
Oh, really? Working?
Yeah. One day I'll be you or Luis. Maybe towards the end of the program or graduation. But by that time you guys will get even better, so screwed.
probably only lasted 4
Really?
Oh, I had one. I like carry like to go somewhere and back all the time.
I got it from nurses as well. There one left upstairs. Excellent.
Hey guys, have you guys figured out yet, or have some idea who usually becomes the spokesperson for you? Who, what, where, how? Abby's right now is the functioning spokesperson. Okay, because you guys have got me from 1 to 3, and you also have me on Friday. I'm gonna flip you on and let you have self-study day because I just talked. You have anatomy lab. It's kind of a Morphus thing where you go and do something with videos with Dr. King. That's why people were asking, do we have self-study today? Yeah, you do. Yeah, so you do. Huh?
Today is self-study.
Today is.
And then Friday is.
Friday you'll have me. At 8. Yeah. Yeah. Because, say what? Yeah, I'm quite sure you have a means by which to find each other when there's like, can we go to the candy store type thing? So you'll have me on Friday from 8 to 10, and then you've got Dr. King from 10 to 12, I think, on Friday. So that we're going to get into something that racism in healthcare is the topic we're going to talk about, and that usually gets kind of bouncy because people have very strong opinions. And I'd rather catch you when you're kind of drinking coffee and waking up and not coming off lunch and, oh my God, I'm half asleep and can I get out of here and go do anatomy like I really want to go do anatomy on lab. Okay, so I'd rather do that then. You have a lecture. Yeah, you have a lecture with him from 10 to 12. And if nothing else, it'll make your coffee work. So we'll do some discussion then. But I want to make sure everybody knows that. And you guys don't have a class president yet. I'm assuming you've got a way to communicate to everybody.
Do
Okay.
you know anything about our
she hasn't given you good guidance, let me call her, because essentially it's her course, and I kind of, because she's not full-time faculty, I'm the course director by name, but it's her course, and I teach the two areas where she thinks it's relevant.
I just didn't want to show up and expect her.
Yeah, she's gonna try to get around to it, she said.
Right. She basically, the whole idea of this course is that a lot of people don't have a very large group of people that they've grown up with. And medicine is about diversity. It just is. And a lot of times people don't realize they have ways of thinking about things that we have to help you with. Otherwise, it can blow up in your face being out in clinical practice. Because people can say things that they don't realize either unkind or not to be said in the workplace. And if you do that, if you're an employee for somebody, they can get sued, and they're not real happy when you do that. So that's what we're going to be talking about. All right. So.
It's already up, right?
Oh, I do. Oh.
Can you guys feel your own TMI?
No, I can feel out of here. But I can see.
Where generally is it?
Do you wanna feel? I really don't care. It's really the.
Why is like
It's like right a little high. It's like right on my. Yeah, it's like a thin.
it's like I feel mine. Mine is like a centimeter going like that. So
Yeah, mine, it's supposed to sit in the fourth and fifth intercostal. Yeah, but mine's a little high. I can see my boyfriend, but I cannot feel myself or see it. Do I do it for both partners?
yeah,
So yeah,
it's
yeah.
gonna have it pointed out to me somehow.
Your partner? Oh, okay, dang it. So we're gonna stay for Floyd. Oh, yeah.
Yeah, we just, I want to show your posts, and no one outside believed me. They thought I was lying. Like, Coombs is in there.
I saw him the whole week yesterday. I asked him, I was like, are we meeting tomorrow or are we having, independent study? Cause I was confused, we never really meet.
What are you
He's like, no,
wanna go home and rest?
and then today he told me,
We don't have class.
You know, you're gonna let them practice on your own.
Yeah, that's fine.
Alright, excuse me, we got rescheduled till 8 to 10 Friday morning.
That was our original time, right?
Yeah, well,
Yeah,
that
was the time
it was
independent.
It's still on the schedule though.
yeah,
Yeah.
and it was independent.
It was supposed to be, yeah.
I really wish that
Well, it's like,
we only got a
compared to just doing
but we don't wanna get into that again. Although, you could take a nap. Yeah, new nail polish. I want it like it's. Colors that actually covers your nails.
no cost for you.
All the mountain crew waits for sure.
He was like, I wanna go to here.
Well, you also.
Like, take your cake back.
When did you get prescribed for it?
The magazine, but I was like,
woke up and not feeling better, but the mental being kind of makes me tired, so I just took it last night. Which kind of defeats the purpose, because like at night I'm sleeping, so I'm like trying to take it like earlier, just to go tonight.
Hey Chris, text me when you're ready. Come over.
Yeah. So I'm like, okay, I'll just take it like that. Yeah. And then I got it. Still like 2 days after. I just glad I'm not nauseous. Like
Were you nauseous yesterday?
I was nauseous on Sunday. Like when I tried to focus really hard, I just like Steve was trying to teach us another question. I was like looking at the computer, and goes, "Can you just wait for a second? I'm gonna lose one." And like we were at school. I didn't actually throw up. I
Self-proclaimed, it's all done.
like actually was nauseous. So like
Yeah.
Alright,
By yourself? Stuff your face. Ain't alone. Right.
Oh, it's like,
Chris.
what?
Wait, sir, alone. Like, Steve.
yeah, it was like a little
Listen, I had
It's
extra
Thursday
spicy
tomorrow,
wings.
yeah. I was saying I have my shoes on, I can't take my shoes on. Tomorrow we can.
Priorities. And I come in at 9:59 like usual.
Oh, go lay out.
Sweet home.
I got some bring some lettuce for you so you don't have to make you feel like you're back at home.
Yeah.
I think I would like.
I was like falling asleep on the
Like George Bush.
No class.
You know what? I'm gonna leave my laptop.
I'm sick. Oh my gosh, everyone. I'm just like trying to.
I'm taking the ball. $10.
This whole Snapchat story is just gonna be him going down the elevator.
You know, just because you said that, I'm gonna do this. You know what I'm gonna do? I'm gonna get PA right now.
I just
PAC, yeah. I'm gonna put that PAC.
Happy else.
I'll be right back, Aaron. We're gonna, you wanna do PD?
Yeah, that's fine.
Like if we were like, yeah, I was like, yeah, I'll stay on it.
So, Megan. Oh, she's gonna go ask?
Yes.
Oh, great. Cause I brought some stuff. I didn't bring.
I wore the PD stuff to school. I wore it to football this morning. And I think Victoria had to sign.
I mean, they were always there.
I brought mine, but it is wrong. I have a gray, t-shirt, it's not PD one, cause I wanna wear the PD one and PD lab tomorrow, but it wouldn't be close enough.
Yeah, I didn't. I wore the NSU, whatever, every week Sharpie.
Oh, yeah.
I wore that one. Yeah, my other one's dirty.
Yeah.
I'll be doing laundry tonight.
Yeah, alright, I'm gonna take my tie off.
I should do laundry too.
We did around. What?
I'm gonna practice.
I didn't mess with did you feel like I mean, on purpose, but you can put things on it. It goes like
Two for thinking.
Are you leaving?
Nicole, I'm just trying to call you. Oh, you want to practice EV with me? I got my stethoscope. If I feel like this, I'm not operating.
You made me nervous for a second.
No, don't you worry. Probably not the smartest thing ever. Robot back out. Hold on. I'm gonna get my stuff out. Okay. And I'm just changing it when we go in there.
You're gonna see us for a full 8 hours, okay?
I wonder if we'd get in trouble if I put my scrubs on already.
No. I'm gonna just.
Someone's asking already to see if we can change that.
Yeah, it's supposed to be after 5 p.m.
What is? But like if we're in the lab practicing.
So we need changing it to like our PD clothes?
Like PD or scrubs, as long as we're in the lab practicing.
I'm gonna go and find her address. I'm
Okay.
just mentioning I'm gonna keep my dog on.
Well, that's what, I think we're ready for that.
Okay.
Well, so where are these so far? So Dr. Peter said Ryan's name and sound like very Christmas. Bye.
What's your name?
I'd rather be in person. I want to be like the second. That way I can ask a comment. Yeah, but not like there's too much. Yeah, not last, but like first.
I'm the last slide for the first everyone.
For what?
What is it? They're not letting us change.
No. Who said that? I just asked Doctor. We asked Doctor or Professor King. And he said you're allowed. Now you're not just like strolling. As long as you're like practicing or like doing something like that, then you're fine.
I'll take it.
If anything, you just change. Yeah.
Yeah.
I am. I can't.
He does keep you in there for a while. He's like easy, like I feel like he's nice. I'm slowly forgetting this entire thing. I was like, I literally just memorized it, so it's gone. Yeah, so I learned everything else. But she was like, I was like, no, they're Nikes.
Are you talking?
She was like,
Are you talking about the boxing or whatever it was?
yeah, the focus shoes. Yeah, she was not talking about it. How long did it take?
Everything about everything,
He
man.
knows.
Well, I think the only reason he knew that was because he was like in the military when they used to get like swag for like clothes. Because he like had the whole dress code down. I'm assuming what they used to have to wear. Because he told us they usually wear them with this color shirt and this kind of pattern shirt. And
I don't want to put
damn.
that dress Yeah, and I'm gonna go change my screw. You can use like the back here, like instead of doing this, you can do that. You can use like the that's what I'm going to use. It's like it's hard, but like not having to just touch.
So I totally forgot my stethoscope, but you can still just like.
I just see why not. I just want what your partner will do.
Look at him. Just ask him. Just make sure that he found it. Oh, you're.
That's it. That's literally it. And fine.
I mean, if you don't do it, like, all of it is fine. It's nice. So three, you have to go to the road at the same time? Yeah, that's. Do that? Cause like, I was trying to get everyone else. Okay. So, like, some of them are always, I know, like, Gail is all through, it's been rooms. But I can't. Oh, really? So you're on, I probably, so someone told me they had same room, okay. No, it's not. It wouldn't be all.
Too hot.
Too hot.
Too hot. I don't even have my clubs down here.
It would be the same amount of time.
I know.
Say reserve.
No, I know. Yeah. I may go back. I may go back.
You can't keep me in this concentrated way, though.
I may.
You got seats reserved all over the
I have
place.
a seat over there.
I need to
Okay.
Today was,
Wait, why?
today was the last straw for us.
Wait, why? What happened?
I know. You're not like trying to have like get bread. Bread was like somewhere in Baltimore, so it would kind of, if you see anything with bread or ginger, red rice food, I'll respond to it, don't worry. I won't take offense to it. If you had bread, that's one of mine. It was so exciting.
But yeah, I'll give you a heads up. Hey, come here, join the discussion. We gotta build some.
Yeah, you do. I already know what it's about. So.
No, I'm gonna do tomorrow.
But yeah, I would say visualize like everything on both sides, and left letter, you never know. Two of them with the bell. I mean, like, I was good at desktop practice. Is that all? Cardio. Right shoulder, right outside.
And then also say
sitting up everywhere with both. And then moving forward everywhere with both.
I mean, look at the thing next to it.
I said it wasn't very.
I'm pretty sure that's what you asked about sitting up.
I'm like, what do you agree?
We do good on everything.
No, so when you're setting, so when you have the left letter, you only do it with the bell, the mitral valve.
Yeah. And everything else is.
And then so that when you have them sitting up, also, so before they lean forward, also take into the diaphragm.
Just over the two things. There now. You go just left, right, there. You don't do the whole.
So, so pulmonary, aortic pulmonary is up.
So yeah, aortic left, line, stay here, so I a little bit. Left forward, forward. Okay, aortic.
Yeah. Oh, well, I'm looking at you like this.
Yeah. So yeah, right left. Aortic would be.
Mitral.
Not really.
Have
you?
Well, it's
Huh?
it's just right third external border. They got
With
no
Bob,
mitral.
which I don't know where he went.
Oh yeah, mitral tricuspid more over to the
That's my opinion. This part is here.
So graduation day, I'm like working in someone hospital, like, hey, Jack.
Right, left.
No, my last.
Or
Okay.
more.
I think mine was actually not. That's something. No, but usually, I'm just saying it's not.
Yes, Mom.
Just in the
Did you? Maybe two more products. I know you have this. We do. What was the sign of emotions? Like last week was the. Oh, what is it? Yes, there we go. Yeah. You make me very proud.
really shocked at my second.
Be shocked.
Well,
You're very clever.
yeah.
Like
I like jazz.
Yeah.
Country.
Everything. Yeah. I like everything but country. I'm not.
It's all lined up there.
Into, but,
All right.
so we're thinking of like good, like home style barbecue.
You guys turn it out. Yeah.
So not
Do you know what she meant by this?
Probably not.
My what? I don't know about
Setting up one.
Yeah, you do it.
Well, you also, this is aortic.
Okay, thank you.
Aortic is in the left sternum border. Sorry, right sternum border. This is the left sternum border.
Yeah, do they?
Barbecue Mission.
Are you talking about?
Yeah, I am trying to.
Yeah, oh, Dr. Tulu, he's like Dr. Cousin
Right. Wait, the laterals both move or the laterals just laterals? Alright. Yeah, we'll figure it out eventually. We'll get the passing grade, hopefully. Oh, I didn't even look. So I make sure I have to say the.
So everybody knows about Friday, right?
No class, no.
Friday morning, 8 o'clock, bring your coffee,
So if I don't say the.
and we'll go at it on Friday morning.
Friday morning at
You
8.
know what the topic is?
Racism.
Racism in healthcare. So everybody's entitled to it. They're being altruistic, but they're
Who's in for? Who's in for?
we're entitled to it, so we're gonna look at it.
Who's in for, yo?
Can I just try to like find it on you really quick? Can we go like in a room? Okay. And then you don't have to come back.
Or institutionalism. Well, it's not like policies, it's irrespective of the people there. So if you think of that institution and its policies exist, and so when somebody comes in and somebody says, oh, this is how we do it. Where does that come from?
I don't know where Bob went. Did he go to change?
And
I'll be
it's
back.
just the way they do business.
So I switched over to no.
That's part of what we'll talk about too, is what is this thing? And how does someone, without realizing it, become part of it? And when you see it, then how are you going to change it? You're part of the group. Well, if it's all part of the institution, exactly. And it's really, the other term you're more familiar with, that every institution has a culture. So that's what we're gonna talk about, because one, it exists. Two, what's this thing called the Affordable Care Law, and how does that affect things? When about 62 million people come into the system that is already structured and already in place, yet they now come back.
When you found it,
The institution of the ability to learn that. And then the third thing is what's happening to America. What's it becoming a racial, racially or it's just a minority? Who's becoming the majority? So it gets real interesting. Yeah. Right, if you think about it, if the institution exists, but the whole majority are changing, and now they have, they can pay. What's the response of the system? So you can't do a whole lot about it. You have to, what my whole intent is to just get to think about that. We're gonna talk. It's more of a talk. It's more of a back and forth, just to provoke ideas to think about things. Because in 2 hours, you know, it's part of cultural issues. Well, cultural issues is about getting you guys to think about things. They realize that it's something different, and
And
something you're coming into it has to be.
in our
Coming in, and you're part of the
And that's when I
profession
went
that
and asked
puts
her,
up
because
there,
Sarah and I
not
were
just
talking
part of
about
the
it.
staff.
Yeah.
that puts up there.
And
There's
I asked
difference
her,
in
I
the
said,
course,
"Well,
there's
can
difference
I show her what
in
she
you're
did?"
part of
But
the,
she was, well, my
the medical
experience.
system.
And you
In a
use the
very,
diagram,
very
and you
different
will
way, and
see
you're gonna be much
the
more
aortic
so
and
than
the
you guys don't stay at the
Yeah.
don't know it.
Harmonic, but we were
I'm writing down that.
Yeah.
Huh?
If you think about it, you're gonna be, yes, when we created this thing some 50 years ago.
I meant to bring my
New.
notes today, but I was running late today.
Oh, wonderful. If we would create some primary.
Who's your partner?
It's George.
Yes.
Yeah.
Industry.
Yeah, easier, yeah, absolutely.
Well, yeah.
But I mean,
Your brother, I just think I don't practice on girls, so. But I'm gonna, I mean, Megan and I will practice, so. I will go with it.
There's like benefits and drawbacks to having like a guy that's like I was kind of my friend, so then you can approach him to do it, but then it'd be probably a little more awkward. Yeah, but it's for a girl. So,
See,
I was gonna be fine with either way.
now, I didn't know Megan at the time, but a year and a half ago, there was a girl that I worked with in EMS that was planning on coming. She abandoned the mission, but, like, if it was her, I imagine that we would have been able to do more of that kind of thing to each other more comfortably, because we're just that way. But she decided not to do this, so. She took a different path. I mean, she has 2 kids, I mean, she should have met you, maybe she would have continued.
Then again, she might be on up.
Well, yeah, but she's 29 and I'm 30 or something, and she decided to wait. And she's gonna think about doing nurse practitioner because she can do it part-time while she works.
She's already.
No, she's not. So she still has to go through BSN and stuff.
Not necessarily. Now there are direct entry MP programs that you basically get your, after 2 years.
No, you have to have your associates in nursing at least.
Sure, yeah.
Yeah, I mean, she was doing Hodges. She was doing Hodges, which it had a little program with Nova to put PA students in or something, but, yeah, so.
I mean, being local, she might have different limitations.
Yes. But the other thing is, she's gonna have her 25 years in at EMS when she's like 43, 45. So she can really come to PA school at 45 if she really wanted to. And her kids would be in their 20s. Yes. Yeah, so, or like 18, yeah, so. Yeah. All right, now I have to go find. Oh, yeah. Oh, you're gonna go home?
All right, I'll see you back.
What time are you thinking?
I should probably send this to my.
Area.
Need anything.
I'm good now. Text me. See you later.
Yeah, exactly. I'm just doing it like.
I see where I put it. I'm getting out here.
went to, BJ's, I don't know if she even knows about labs.
Maria?
No, no, this, no, this Maria, not that Maria.
Oh.
I know where she's in the.
She's in the lab, yeah. No, it's okay. All good.
Sorry.
No, no, it's fine.
Yeah, I'm just gonna.
Miss Maria said we can call her Red or something. Something with red.
Gender.
Red Maria.
Jen. Oh, yeah, of course. What is that calling it?
Muscle two.
We just do.
Yeah, so if we get done with that, then we'll go into the endo.
What do you guys do like when you?
Well, I mean, I don't know, we just generally like, just go slide by slide on it, and talk it through amongst ourselves, make sure everyone knows it before it's time to move on, just to come up with a, you know, hey, this is the question you could ask, this is the question you could ask.
I know. I'm like, really?
Come up, like, I
I
mean,
just checked the email.
You guys are doing that at 3?
There's
oh no,
something
five
here.
to 8. Oh, well, we don't have a room at 3, I mean, I don't care what we do. We can start early, I'm okay, I mean, I don't think the ADs are around, they're in class, so that's okay too. I'm good with it. I mean,
Where do you guys go? How much are they? I'm trying to find new study habits here for next semester. Laptop issue.
well, I don't wanna tout mine as efficient. I mean,
It's kind of slow.
it could be slow,
Mine's really slow.
it could be slow as far as how many, like, it's slow and thorough, yeah, but I mean.
I don't know. I'm doing myself, really.
Oh, nice. So, oh, good, well, I'm glad. You're back up to over 75 now.
I have to keep making a certain grade on it.
What about Adley?
Not very well in any, anatomy, speaking of like physiology, I really like.
I like physiology a little more, I can think through it, and anatomy, I'm just like, oh, the obturator canal, I can't stand it. It's the obturator.
The
It's like,
nerves.
I'm
The nerves are really frustrating.
if I was gonna be a neurologist or an orthopedic surgeon PA, you know,
Yeah.
I would care, but
And I feel like part of my frustration comes from the organization of the slide. Because it goes like muscle, nerve, blood vessel, nerve, muscle, nerve, blood vessel, nerve, blood vessel, muscle, nerve. I think it's just like,
And then sometimes it goes back to like most information like covering.
Yeah.
Just have like stuff to it.
yeah.
And you have a good way to be able to tell like what way the knowledge is really long to when they're facing all sorts of things side you're looking at. And I know
Like,
being
well,
able to
I
find
guess
tips,
some of
but
the language.
I mean,
Oh.
like every time I look at
It's
it, I'm
like
like,
really like go over it.
I'm not sure I have a
memorize it,
good
and
way.
try to understand, like, oh, actually, no, it's not.
Yeah,
Like,
I don't like to
which
just
one?
read it. I like to actually like.
That was a
go
tough picture to look at.
engage
I
And
look
then think
at,
about it.
okay,
That's
so
what's
you have to be able to tell,
Yeah, sometimes I like draw
you have to
stuff.
be able to tell both
Person, I can't.
directions. So, if you can isolate, find yourself a picture, here we go. I'm looking to get at, like that. Okay,
Jorge,
you have to be able to-
hey, making some slides
I don't
for
know if you can get any pointers other than,
Anki.
if you're looking at this side,
You want me to send you those?
we
Or are you making them yourself?
Yeah.
Yeah?
yeah.
I don't know how yet, but I'll figure it out.
Does anybody have the second PowerPoint
Okay, yeah,
for,
so now, you can picture that going forward.
Yeah, it's on Google Drive.
the second one is, it's on Google?
Everything is up.
It's on Google. I have a. I assume it's on Google, but I have a thing.
You have a thing?
Yeah.
Can you elaborate what kind of thing?
I mean, I have various kinds.
So, watch, so here I am, right? I have sockets out here.
I think John got like a
This is
design
pointed
forward,
forward.
buddy.
So this,
Yeah, James had one, but his file was
if this,
corrupted.
if you try to make this,
Well, I haven't opened it yet, so.
this is the, this is a lab So when I look at this, no, this is a sagittal. But it's of the, when you see this socket here, you know that's where the hip is, the ball of the femur, the head of the femur, I'll use the right term.
Oh, she's your friend.
So the head of the femur is there. This thing points forward, so now you know, okay, that way is anterior. This, you're looking at it from out to in, so you're looking from the lateral side.
Yeah. So when I was doing.
So this, if I try to make that my left hip,
Why do you have to do
okay,
it?
I'm putting the ball here, but it's on the other side, so it's not left. I guess that's where I'm, do you see that or no?
This is up here.
This points forward, regardless of what side you look at. So this points forward, so I know that's anterior. So now I've got to figure out, okay, the socket for the ball to the head of the femur is on that lateral aspect of the hip, of the pubic bone, right? So it has to be the right. If I try to make it the left, I'm putting the ball in this way instead of this way.
Turn around.
Well, you don't know, I mean, that's a harder one for me, actually, because, I mean, you don't really know if that's posterior or anterior. It's harder to decide.
Even with the painting.
Did you wanna practice?
Well, yeah,
Just like to
I would say that, but I have labels and it's make it like easy. Yeah. I don't know if he would give you half of the sacrum to help with figuring it out. Yeah, I don't know.
That is the right side.
That is the right side. But you can't see the pointy thing. Now you look at the width curve of the sacrum, and that's what helps you.
I have to look at it in like the essential anatomy.
Yeah, I would, yeah, yes. Yeah, I would do that. Yeah, do you have that?
Yeah, I do.
Okay.
One of my iPads.
Yeah, I would. I hope that helps. If you have some other pictures that I can look at, I might be able to help
Yeah.
with the way, and maybe someone else has their way to do it.
I'm trying to see if this axis clicks. What is that?
That's next product.
Pretty sure.
Yeah.
Never looked at any of them. Falling behind.
Shit is what I think.
So we had just had anatomy test 2, right?
Oh.
We would need 3 more than the other.
You did 3 more days?
Yeah, we have 5. 4 of them now. This is one of the 20% of anatomy are the 3 studies.
Oh, right.
Right.
Right. What do you think?
You don't know what you're
No, that's true.
I was just gonna bring one there to print.
Oh, man, why do I have to? Anybody want something?
I kind of do.
I can't. You can't.
I can't. And whatever you want to run through this, take your time.
Okay. Drawing the picture as soon as I finish the picture.
Cool. Still don't really know it, but pick it up. Yeah.
Oh, I don't.
You shouldn't know it yet.
Not till tonight, actually.
You should know it tomorrow at 12:45.
Oh, no, tomorrow by 12.
Yeah.
Are you coming at 12 too? Okay.
No, that's fine. We can just go over.
Where are you going to get a haircut, George? Because I need to go too. Where are you going for a haircut?
Well, this place that, Jason told me to go.
Oh yeah, is it good?
Georgia Downs or something on college.
Oh yeah? It's a barber or a stylist?
Oh, he does?
Okay.
I don't have to
Yeah, you're a stylist.
Next Wednesday.
I used to go to a very good stylist.
I'm down
I don't want to go to
after
her
exam
because she's like 35
this is gonna be, he told me, but,
No.
you know, I can't go.
You have to go there because I could tell you where I go. Used to go to Kristen, my hairdresser. She's awesome.
I should have asked. I gotta.
I was supposed to be.
Okay. Cool. I just need to go to the barber. I already have a new haircut I want.
I'm gonna tighten up.
Yeah.
I'm gonna lose money. I don't see much good coming out of it.
You leaving, George?
I could win.
Yeah, I mean, I think it's working.
Okay.
Okay. I'll be back though.
Oh, okay, yeah, I'll be here.
I'm just running to grab a haircut and I'm coming right back.
Yeah. Where are you going?
I don't know, some place Jason told me to go.
Oh, okay.
He used to have a hairdo so. What's that?
Cool. He's trying to convince me to go to the casino. Yeah, go for it. What are you, palpating your femoral, I can't have your feet on.
No, come on. Gambling and strip clubs are out of my freaking deal. Unless somebody's giving me cash to go to.
Well, if he's
Nah,
not
man.
Well, it doesn't last long either.
That's it. How about you, Mark? You like to gamble?
No, I'm not a big gambler. No, not at all, actually. I know, but it doesn't really excites me. Idea of spending and losing money because that's what
Exactly, yeah.
happens.
I hate losing money more than
I'd
I
rather
like it.
spend it on,
That's my problem. That
you
is
know,
a problem.
strippers
That's a
or
problem. That's a
prostitutes.
big problem. Bartek and I just want to take our $100 and get hammered. So.
Yeah, get a hammer and get bitches.
That's a win.
Yeah, that's a win.
He just likes losing money.
Whatever. I'd rather gamble on money where there is a chance I could win something than just drink it all away.
That makes sense. All I know is I was up $500 at the casino and I lost it all. So.
Oh yeah.
Does that get you excited to go back?
No. I lost it all. I made $50 to 500 and I lost it. Because I got so excited. I was like, oh my god, what do I do?
What do you do about that
I
money?
keep going.
What were you playing?
What? Just, it was, what's it called?
Blackjack?
It was blackjack, but it was like the computer one. There was like 5 people sitting around, like you all play, like, so it was virtual.
You know, I learned in my statistics class that house always wins, and once I learned that, I won once, and I played. I think